Doc, let's start.
Okay, so we are talking about the examination of the locomotor system today. And when we talk about the locomotor system, we are talking about the system that deals with the muscles, the bones, and the joints. So the locomotor system or the musculoskeletal system is composed of muscles, joints, which join these structures. So when you take the muscles of the body, and each joint is designed to perform a specific set of motions. So for example, if you take the shoulder joint, it can do extension, flexion, it can do internal rotation, external rotation, it can go round and 360 degrees.
Adduction.
And adduction, yes. Any abnormality in any of these structures will produce a malfunction of the musculoskeletal system. And that will be the focus of our discussion this evening. Okay, so when you have a patient coming to you, how will you know that the patient has a problem with the musculoskeletal system? By the history. So there are several questions that you need to keep in mind when a patient comes to you with musculoskeletal problems. You want to find out if the problem is a local one or is generalized or is systemic. You also want to find out if the problem is symmetrical. So does it involve both sides of the body? Is the functional abnormality due to a force that is acting on the joint, or is the problem within the joint itself? And then you also want to find out if there are any systematic or systemic manifestations. A rash,
Evans,
or
what's
a
the problem?
fever.
Okay, no, continue.
So that the patient is complaining of is related to an injury, or whether it was caused by an injury. And are the joints affected? Are the joints inflamed? Or is there pain? So when you use arthritis, it means inflammation of the joint. And when you use arthralgia, it means pain at the joint. Okay. So most of the time, if you have arthritis, you also have
I don't know if it's
You can't hear. Is it better?
Yeah, we can't hear you properly. The signal keeps. Yes, I
Can
see.
you
Yeah,
hear better now?
yes, madam.
Okay. So I was saying that there is a difference between arthritis and arthralgia. When you say arthralgia, it means pain in the joint. Arthritis is inflammation. So every time you have
Hey,
arthritis, there's also arthralgia. Can you hear, or is still bad?
Yeah, I think it's a problem from the network.
Your network
Okay,
or network? Because I can hear.
It keeps on breaking.
Okay, let me change the position. I think it's probably where I'm sitting, because I came downstairs to try and
just want madam to change their position.
I came downstairs to run away from my daughter, but it seems I'll have to go upstairs.
Madam, stay there, don't go anywhere.
Give me again. I've already left. Don't worry.
One person of this year in design on there.
To run away
Why
from
na
her.
kasano? Ade mafro bi o.
I will throw.
Mafro
Maybe
bi
they
o.
doesn't feel be there will be the end.
Usura let me some body but no person o person o kan kasantwie. Ade obi ti fie nu aba na.
Hey.
Ekute bi anim ni re.
Hope this will be better. Okay, so what I was trying to say is that when you have arthralgia, it is pain at the joint. Arthritis is inflammation at the joint. Usually, when you have arthritis, there's also arthralgia. But it doesn't mean that every time you have arthralgia, there's arthritis. What this means is that when there's arthritis, that's inflammation. And as part of the 5 cardinal signs of inflammation, there's pain. So arthralgia will always be present. But you can have pain without inflammation. For example, if you hurt your leg, maybe you're playing football and then you have an injury to the leg, you may not necessarily have an inflammation, but there will be pain from the impacts of maybe the ball that hits your leg. Okay. So if you suspect that the patient has arthritis, you have to find out whether it's inflammatory or non-inflammatory. So the difference is that when it's inflammatory, there's pain at rest, and then it becomes worse when the patient moves. So the patient will tell you that, oh, it's usually in the morning, when I wake up in the morning after sleeping, that is after sleeping, when they move, then it becomes worse. But when it's non-inflammatory, it becomes more painful with activity. And when they rest, it eases up or the pain goes away. So it's very important for you to distinguish between the two. Because, for example, a neoplastic condition like cancer of the bone can give you a non-inflammatory arthritis. So it's very important for you to distinguish between the two from your history just by asking what causes the pain to be worse. It helps you to understand better. Now, it's also important to know how many joints are involved. So if it's one joint, it's a monoarthritis, it's 2 to 4 joints, it's oligo, and then more than 4 is a poly. Okay. Then, is it large joints or small joints that are involved? Moving to drug history, you want to find out if there are some medications that the patient is taking which are associated with adverse effects on the musculoskeletal system. So, for example, steroids can give you osteoporosis. Statins are medications that are used to lower cholesterol level. So they can give you a myositis, a myopathy, or a myalgia, that is pain in the muscle. Then angiotensin-converting enzyme inhibitors. They are types of medications that are used to control blood pressure. So they can also give you pain in the muscle and the joints. Then anti-epileptics can also give you arthralgia, that's pain in the joints, and then osteomalacia. Quinolones are typical levofloxacin. They can cause tendon rupture. So it's important to keep these things at the back of your mind when you're taking the family history. When you're taking the drug history, sorry. Then when it comes to family history, we know that sickle cell disease commonly presents with bone and joint pain. And so we want to find out tuberculosis is also common in our African setting. Social history. Basically, the aim of social history is to look for functional difficulties that the patients have with normal activities of daily living, like bathing, dressing up. Is the patient able to climb stairs, or do they need an aid? Okay, so you want to use this to give you an idea of how bad the functional impairment is. Then it's also important to take a sexual history because some sexually transmitted diseases can be associated with arthritis. So gonorrhea is an example, hepatitis B is an example, and then non-gonococcal urethritis can give you a reactive arthritis. So your sexual history is important. It might seem irrelevant, but it is relevant. Okay. Then other aspects of the social history like alcohol. For example, if the patient abuses alcohol, then trauma might be a possibility, or nerve paralysis. If the patient smokes, then you are wondering, is it a lung cancer which has spread to the bone, giving the pain in the bone, or if the patient is a drug addict, could this be related to hepatitis B or HIV infection, or maybe they were high on drugs and then they fell and experienced some trauma. Okay. Now you also want to interrogate their diet. Is there any vitamin deficiency? For example, people with vitamin D deficiency would have vitamin osteomalacia, and then scurvy is also a manifestation of vitamin C deficiency, which gives a manifestation in the bone. Vitamin C deficiency, commonly what we know is that you have bleeding gums, but it also leads to brittle bones. Okay. Okay. So that is for your history. Musculoskeletal system examination is a very cumbersome and detailed examination. And so when you take the history and you have these things in the history, then you move on to do a detailed musculoskeletal exam. Okay. So on a screening examination of a patient who has no musculoskeletal problem and in whom no gross abnormalities have been noted, it is enough to just inspect, look at the trunk, and then ask the patient to do active movement of all the parts of all the joints. That's enough. But if the history points to a problem with the musculoskeletal system, then you would want to do a more detailed examination. So in musculoskeletal system examination, we do inspection, palpation, and manipulation. There's no auscultation here, and there's no percussion here. Okay, so it's just three things: inspection, palpation, manipulation. You start by dividing the musculoskeletal system into functional parts. So functional parts means the upper extremities, the lower extremities, the spine, and then the trunk. Okay. So once you have these functional parts, it's easy for you to, Kevin, what is it? Are you done chatting? Okay, so why do you come? You just want to see. Okay, you. All right, let's go on. So in the upper extremity, you start with the shoulder. In the lower extremity, you start from the foot, and then you come up to the hip. So inspection. The main thing for inspection is comparison. You want to compare the right side of the body to the left side. Is there any symmetry? If you are in doubt, use your own anatomy. Okay. If you see something on the shoulder joint, you are not sure, or on the arm or any other part, you are not sure, you can look at yourself and see if you find that abnormality there. Of course, we are assuming that you are normal. Okay. So concentrate on one part of the body at a time. What are the things that you are looking for on inspection, apart from looking for symmetry? You want to find out if there's any discoloration, and typically redness is a sign of inflammation. So you want to look out for that. You want to look out for any soft tissue swelling, any bony enlargement, any wasting, any deformity. As an example, if you have a fracture of, let's say, the lower leg, the leg, you would find that the bones would be at an angle to each other. So maybe it might be hanging in a way. There'll be some abnormal angulation that will tell you that there's probably a fracture at that point. Okay. So we move to palpation. So on palpation, it's very important for you to be observing the patient's eyes while you are palpating the structure. We know that some people may not express pain by shouting or maybe making and giving an expression, but their facial expression or their eyes will tell you whether they are in pain or not. And so you want to be looking at the patient's face while you are palpating. And the most objective indicator is involuntary muscle movement around the eye. Some people are very good at masking their pain, but if the patient is in pain and you look at the eyes, you see that there'll be some involuntary muscle movement around the eye, and that should tell you that the patient is in pain. and pay attention to where they have the pain, and then what maneuvers gives the pain. Then we move to active movement. Active movement means that you ask the patient to perform the movement. So if you take the elbow joint, for example, the range of movements are flexion, extension, supination, and pronation. So when you ask the patient to do these things, that is called active movement. Okay, and so that is the manipulation aspect of the examination. So we have inspection, palpation, and manipulation. So active movement, ask the patient to do the movement. Then as you ask the patient to do the movement, you observe, and then you see where the limitation of movement. So once you observe where the limitation of movement is, then you would do the passive movement. Passive movement is you manipulating the joint through a series of passive movements through the entire range of motion. So the same elbow joint, you yourself would take the hand of the patient and then flex and then extend, whilst having an impression of the range of movement. So when you hold the hand and then you flex and extend, you will have an idea whether there's resistance to the movement, whether the joint is stiff or not as you are doing it. You shouldn't be high-handed when you are doing it. Don't be moving it like with so much force and with so much speed. You have to be gentle as well. When you are passively manipulating a joint, note whether there's a reduction in the range of movement, whether the patient has any pain. So whilst you are doing the manipulation, you are looking at the patient's feet. You also want to know whether crepitus is produced. How would I explain crepitus? So crepitus is some sound like cracking sound you hear when you are moving the joint. And then you also want to find out if there are some abnormal movements that are produced. So now we'll do the detailed examination of the various parts of the musculoskeletal. So on the hands, you want to look at the hand, you want to look at the wrist, note if there's any color change, any enlargement, any temperature change, any deformities like contractures or abnormal angulation. And then look at the nail and then also the cuticle. Then check the thenar and hypothenar eminences. So the thenar eminence is the fleshy part which is near the thumb, and the hypothenar eminence is the other fleshy part of the hand which is near the little finger. Okay, so check if those muscle groups have become hypertrophied or atrophied. And atrophy usually indicates that muscle or nerve problems. Okay, that leads to atrophy. Then you ask the patient to make a tight fist with both hands. And then you ask the patient to grasp a small object. It may be a pen. You ask the patient to grasp it and look at how tightly they are able to grasp it. Then you can also observe.
Nick, just I hire Nick.
I can't mute his microphone. He has to mute his own microphone.
Okay.
Just
So we know that for the various groups, the interphalangeal joints, you have flexion and extension. Then when you come to the metacarpophalangeal joint, you have flexion, extension, and then there's hyperextension as well. Then you come to the elbow. So the elbow is flexion, extension, supination. But of course, it starts from observation. So you look for any thickening, any subcutaneous nodules. Then you ask the patient to actively flex and extend, and then you also do the passive movement. So basically, in fact, when you go through all the systems, it's basically that's all you do. Inspection, palpation, manipulation, and the manipulation consists of passive movements and active movement. You let the patient do the active movement first by letting the patient do the range of motion. Then you would come in with the passive movement. So the shoulder joint has so many components. And of course, you palpate as well, and then you do the various ranges of movement. So the temporomandibular joint is a jaw. So you ask the patient to move the mouth and then to move the jaw from side to side. And then you palpate it yourself and listen for any crepitation or crepitus whilst the motion is being performed. So the spine, we know that the spine is divided into the cervical spine, the thoracic spine, the lumbar spine, the sacral spine, and then the coccyx. So you examine each of them in turn. So for example, if you take the cervical spine, you look at the curvature of the spine. Usually the cervical spine has a lordotic curve. What it means is that it curves inwards. When you follow the normal curvature of your spine, you see that the cervical part sort of goes in, then the thoracic part comes out, then the lumbar region goes in again. So that is the normal curvature of the spine. So you palpate for any tenderness, any crepitation. Then you ask the patient to perform passive movement. The chin on the chest for flexion. Then you do extension, you go as far back as you can. Then lateral flexion by turning to the left and then to the left and then to the right, and then rotate the entire neck. So it's basically, the whole examination is like you're doing an aerobic session. You're testing each part of the body, the musculoskeletal aspect, just trying to find out if everything is as it should be. So the thoracic and lumbar spine, the thoracic part has the outward curvature, but when the outward curvature is too pronounced, that's a kyphosis. That's what we call a hunchback. Then you can also have a lateral curvature, that's a scoliosis. So the spine can curve either to the right or to the left. And then, of course, you look for the lumbar lordosis in the lumbar spine. And then you do the full range of movement again. Yeah. It's all the same thing over and over again. When you come to the foot, you want to specify, hey, the meeting went in 10 minutes. How come it goes so fast? Probably because we were waiting for people to join.
Yeah.
Okay, let me try and speed up. Basically, the whole thing is very simple. On the foot, you want to look at the longitudinal arch. Pes planus is flat foot, and then abnormal elongation is pes cavus. So if you have like an abnormally elongated longitudinal arch, that is pes cavus. Then there are some abnormalities of the foot. You can have hammer toe when, especially for women who wear a lot of pointed shoes. So you realize that the toes sort of converge, okay? And then you can also have pressure areas or calluses over the toe, also because of constantly wearing shoes. Then the usual range of movement, flexion, extension, ankle, virtually the same thing, the knee, the same thing. Okay, so in fact, the whole musculoskeletal system, what the take-home point, what I want you to take home from the whole session is that when you're examining the musculoskeletal system, you want to go through inspection, palpation, and manipulation. And for the manipulation, you are concentrating on the particular range of motion or the particular range of movement restricted to that particular muscle or joint group that you are checking. And you start with active movement by asking the patient to do the movement themselves. So that's active. Then, as they are doing the movement, you are watching them. You are seeing where there's restriction or stiffness of the joint. Then you would come in and do the passive movement, where you would now look at how the movement is being done and also look at the stiffness of the joint as you are moving. Okay, and that's to give you an idea of what could be going on with the patient. So basically, this is it. This is examination of the musculoskeletal system. Are there any questions? No questions. I have to start examining you.
No, madam, don't bring examination or else
Any questions?
go
It
ball.
means either you weren't paying attention or
No, we are paying
you are
attention. We are
confused.
just enjoying the explanation.
Maybe you are confused. So you
Madam, maybe I'm confused.
what are you confused about?
Madam, the lesson is fully home. The
So if
lesson
you
is
go
fully
by
home.
Pardon?
The lesson is fully home. We
Okay.
understand the lesson very well. It's fully home.
Actually,
So
muscle system examination is one of the easiest when it comes to examination. It's very, very straightforward. Okay. I'm sure a lot of you can relate to it because it's on your body, it's the joint. It's easy to understand. So no questions.
No, madam.
Okay, so when is the semester supposed to end? Normally, if things were normal.
We're supposed to start exams on the 15th of June, and then the last
Hey.
paper will be on the 5th of July. Yes.
let me buy.
Hey, bro, today, 15th of what? June.
Yes, sir.
And
15th
I
of
have bombed
June. 15th of June is supposed to be the start of the end of SEM, and then 5th
Hey.
July is the end of the last paper.
We'll be able to finish clinical methods, and if we are lucky, we can go
Just
through
warning.
the-
Don't talk again.
15th June. Like seriously?
Yeah.
Madam, so how are we going to write the exam?
Yes, madam. Seriously. Seriously.
The school is trying to come up with a system whereby we will have to set the questions, but the questions will have to be written. And I was telling the HOD that written questions will be difficult for us to administer because I've always liked multiple choice questions. And for a subject like pathology, because it's a lot, the written is difficult, but if it's MCQs, once you read the notes, you have a fair idea if there are options, you'll be able to choose from them. But it will be difficult for you to say that somebody should explain inflammation, for example, because it's a lot of reading. So they may not remember exactly the things that go into inflammation. But if you ask a question like the following are mediators of inflammation, at least you can recognize that, oh yes, pain is part of them, and then you choose pain. So I was trying to explain to him that this was a directive that came from KNUST. So I don't know if the university is going to sit and meet and then further discuss. But it looks like a lot of people, like myself included, we just got onto this Zoom thing. So we haven't even gotten halfway through with our lectures. So it's going to be very challenging to actually adhere to the timetable. So
Even the HOD himself, he has not started anything with us. He himself.
Not even a slide. Not even a slide.
Not even one slide.
Hey!
I mean, it must be a big challenge for him to get
Then
on.
it will be reviewed.
My assignment, you know.
Manik,
Madam, but I thought Ken
HOD
Chef was saying
electronic.
that give us assignment and they should use that as
I'll ask him about it and then see. Maybe I can give you
how
some
to use
assignment.
that one, madam.
Oh, I don't think we can just rely on assignments for assessment. You need the examination too. Assignment at best,
Because
that's 30.
Madam, You are giving me high blood pressure.
Why?
Examination.
Have you ever gone without writing exam?
Examphobia.
Madam, here's the situation. Here's the situation.
Elisha,
Madam, Christian's hand is up. Oh, probably he wants to say something.
Yeah, please ask your question.
Your microphone is muted, Christian.
Madam, please, my question probably might not be yours to answer, but I don't know, maybe you might give us a fair idea. It's about how to roll out our clinicals this semester, the clinical rotation.
Yeah, I
With
was
this
thinking about the
COVID-19
same
and this.
thing. So for family health, I teach there too. For family health, what we decided to do is to go.
What?
Under the circumstances. Yeah.
that means we'll make do with the video,
Madam,
right,
so
madam?
the exams, maybe the exams is important to me. So what is the final this thing with the exams?
Final
I
solution.
think the university will have to decide and communicate with us.
Okay, we hear.
Madam, try and convince them.
I have a question.
Yes.
Mabel.
Madam, you should convince them, they'll hear you. Convince them, okay?
No, it's all right. Mabel has a question. Mabel, please ask.
Please ask your question.
Okay.
You have
Less than 1
please,
minute to be fast.
Please, I want to know why the old people usually have problem with the joint pain and then muscle pain.
It's part of old age. Usually what happens is that they have a lot of osteoarthritis, which is a disease of the elderly, and that usually presents with joint stiffness. So it is, what I'll say is that it's a disease of the elderly. That's how best I can explain.